Hemoglobin is quite high yield for this exam. Lots of testable topics surround hemoglobin physiology and pathology. So let's get to it. Check out this hemoglobin molecule. Adult hemoglobin is a polypeptide comprised of 2 alpha and 2 beta subunits. Do you remember the other major kind of hemoglobin that occurs during development? Yes, fetal hemoglobin. And how is fetal hemoglobin different than adult hemoglobin? Well, fetal hemoglobin is comprised of 2 alpha and 2 gamma chains. Each hemoglobin subunit has a non-protein heme group containing a single iron atom. This iron atom forms a strong covalent bond to a histidine residue in the globin chain. There is a T or taut form which has a low affinity for oxygen in the heme molecule, and an R relaxed form with almost 300 times greater affinity for oxygen. Does carbon dioxide bind to heme? No, it binds to other parts of the hemoglobin protein to form carbaminohemoglobin. Carbon monoxide, on the other hand, does competitively bind at the same heme site to form carboxyhemoglobin, which we'll discuss in the next fact. An important concept to understand is positive cooperativity. What does this mean? This means the binding of the first oxygen molecule pushes the hemoglobin into the R or relaxed state by tugging on the histidine residue. This makes it easier for oxygen to bind to the other 3 heme groups. So the only time hemoglobin is in the taut state is when no oxygen is bound, and it's in the relaxed state when 1 to 4 oxygen molecules bind. This explains the sigmoidal nature of the oxygen-hemoglobin dissociation curve, which I'll show you in a bit. Negative allostery occurs when something like 2,3-BPG binds to hemoglobin, stabilizes the taut form, or reduces its affinity for oxygen. Do you recall when humans physiologically produce 2,3-BPG? Correct, at high altitudes. Now why does this make sense? Well, because in conditions of low oxygen tension, the hemoglobin must release oxygen more readily into the tissues. The 2,3-BPG binds more hemoglobin and allows more oxygen to be delivered to peripheral tissues where oxygen is most needed. Now a quick word about fetal hemoglobin. Here is an adult hemoglobin saturation curve, which is sigmoidal due to, correct, positive cooperativity. After the first oxygen binds, the hemoglobin becomes relaxed, so the next 3 bind really quickly, which you see as a rapid rise in the curve as the oxygen saturation shoots up. Now fetal hemoglobin is comprised of what? Correct, 2 alpha and 2 gamma subunits rather than 2 beta subunits. Fetal hemoglobin has a higher affinity for oxygen than adult hemoglobin. Here you can see the difference in oxygen saturation curves with the fetal hemoglobin curve being left shifted. Now this makes sense because the fetal blood has to acquire oxygen from maternal blood, so it has to bind with greater affinity. What makes fetal hemoglobin's affinity so high for oxygen? Well, as we mentioned earlier, 2,3-BPG is a molecule that binds hemoglobin in order to decrease hemoglobin's affinity for oxygen and increase oxygen delivery to tissue. Fetal hemoglobin actually has a decreased affinity for 2,3-BPG, so its affinity for oxygen is thus much higher because we want the fetus to have as much oxygen as it can get from mom's blood. Finally, fetal hemoglobin will make up nearly 100% of the total hemoglobin from week 10 up until birth. You can see this here in the graph by noting that both the alpha and gamma subunits are those that are the most abundant during this time period. However, after birth, the fetal hemoglobin concentration will start to decrease and will be replaced by adult hemoglobin. Notice that the gamma subunit is decreasing over time as the beta subunit increases. Generally, this transition process between the 2 hemoglobin types takes about 6 months. Flash quiz. The lungs tend to blank, and the chest wall tends to blank. The lungs tend to collapse inward, and the chest wall tends to expand outward. Let's talk about a couple of highly testable conditions that can modify the effectiveness of hemoglobin, leading to tissue hypoxia. Methemoglobin is the oxidized form of hemoglobin, containing ferric, or Fe3+ iron, rather than ferrous, which is Fe2+. This form of hemoglobin is less effective at binding oxygen, and the patient gets a functional anemia. They can then become cyanotic. Interestingly, methemoglobin has a high affinity for the cyanide ion, which has important therapeutic implications that we'll come back to. So how can you get methemoglobinemia? More commonly, you get it secondary to oxidizing medications such as nitrites, dapsone, and benzocaine, which makes sense since ferrous iron is oxidized to produce ferric iron. Now, when should you be alerted on step 1 to a patient who might be taking dapsone? Well, someone who's on multi-drug therapy for leprosy. Methemoglobinemia can also be an inherited disorder. The most common inherited form is autosomal recessive. Do you know what enzyme is deficient in this disorder? Correct, cytochrome B5 reductase. This enzyme converts methemoglobin to hemoglobin. So how do you make the diagnosis? The classic presentation here is clinical cyanosis with an oxygen saturation on routine pulse oximetry of 85 to 90%. But when you get a blood gas, the arterial PO2 is normal and the blood is chocolate brown. Acquired methemoglobinemia can be treated with IV methylene blue and by stopping the offending drug. As I mentioned, methemoglobin preferentially binds cyanide over oxygen, something that can be leveraged in cyanide toxicity. So how does that work? Well, you give the patients nitrites to convert hemoglobin to methemoglobin. Methemoglobin will then bind the cyanide and remove the cyanide from circulation. Thiosulfate is then used to bind this complex methemoglobin cyanide molecule, forming thiocyanate, which is then excreted in the kidneys. Carboxyhemoglobin is typically caused by carbon monoxide poisoning, where hemoglobin binds to carbon monoxide rather than to oxygen. In fact, carbon monoxide has almost 200 times greater affinity for hemoglobin than does oxygen. CO binding means that there's less hemoglobin available for oxygen transport. It's similar to a school bus, where there are only so many seats. The carbon monoxide is like a passenger that won't get off, so there simply aren't as many seats available for oxygen. So you can imagine that oxygen can't get where it needs to go since there are no seats. On top of this, there is a left shift in the oxygen-hemoglobin dissociation curve, which means less oxygen offloading in the tissues. So carbon monoxide does two very detrimental things. It will left shift the curve and bind the oxygen sites on hemoglobin with a higher affinity. This is what will cause flattening of the curve. So how can we tell the difference between someone with methemoglobinemia and carbon monoxide poisoning? Methemoglobin makes the patient cyanotic, while carboxyhemoglobin makes the blood bright red. So, would you expect a patient with carbon monoxide poisoning to have a decreased O2 saturation on pulse ox readings? Well, no. In fact, the pulse ox might even read 100% O2 saturation because it can't tell the difference between oxyhemoglobin and carboxyhemoglobin. Carbon monoxide poisoning also often causes a cherry red appearance of the skin. Thus, you hear the mnemonic, when you're cherry red, you're dead. Another buzzword associated with carboxyhemoglobin is headache. If the question stem gives you a left-shifted curve and also describes a patient that has a recent onset headache, think about carbon monoxide poisoning. Remember, carbon monoxide is an odorless, tasteless, and colorless gas. The patient may not have known that they were even exposed, so be sure to look for headache as an early sign of exposure in a patient that otherwise has no history of headaches. Hey, speaking of headaches, what's one thing you want to think of when a patient presents with the worst headache of their life? Correct, a subarachnoid hemorrhage. And what do spontaneous subarachnoid bleeds usually stem from? A ruptured berry aneurysm. Associated most commonly with what disease? Right on, autosomal dominant polycystic kidney disease. My apologies for the tangent, however, it's important to make these kinds of associations when studying for this test. We'll discuss a bit more when we get to the renal sections. Finally, how do you treat carbon monoxide poisoning? Well, obviously, you want to get the patient away from the source of carbon monoxide, then you're going to want to treat with 100% oxygen ASAP. Flash quiz. What color will the blood appear in methemoglobinemia? Chocolate brown. The oxygen-hemoglobin dissociation curve is another high-yield concept that you'll see on boards. Recall from our discussion of hemoglobin that the binding and unloading of oxygen from hemoglobin shows positive cooperativity, meaning the affinity for oxygen increases as each site is filled, thus resulting in a sigmoidal shape of the dissociation curve. So how does this compare to myoglobin? Well, myoglobin is a monomeric heme protein similar to the alpha subunit of hemoglobin. And because it's monomeric instead of hemoglobin's multimer, it's not capable of having these allosteric reactions. So as you see here, myoglobin has a hyperbolic non-sigmoidal curve where it has a greater affinity for oxygen than hemoglobin. Interestingly, the hemoglobin curve can shift right or left under specific conditions. So why would the curve shift, and why does it matter clinically? Well, a shift in the curve in any direction simply means that there is a change in the affinity of a hemoglobin for oxygen. A shift to the right signifies a decreased affinity of hemoglobin for oxygen. What this means is that there's more unloading of oxygen to the tissues. Think for a moment about situations where this would be helpful. For example, when you're exercising, your muscles need more oxygen, so it makes sense that the curve shifts to the right, meaning hemoglobin at the same partial pressure of oxygen will be less saturated since oxygen is being unloaded in the tissue. Well, a number of factors will shift the curve to the right. A mnemonic to keep in mind is ACE-BATS, right-handed. Acid, CO2, exercise, 2,3-BPG, altitude, and temperature will all shift the curve to the right. Now, what do all these factors have in common? They all signal a need for more oxygen delivery to the tissues, and they stabilize the taut form of hemoglobin over the relaxed form. This allows hemoglobin to better unload the oxygen. So this makes sense, right? Active muscles, like during exercise, locally cause an increase in local temperature. They increase carbon dioxide release and increase acidity. 2,3-BPG is synthesized in red blood cells from 1,3-BPG. Hey, 1,3-BPG sounds familiar. Do you recall from where? 1,3-BPG is an intermediate in glycolysis. More on this in the biochem chapter. Outside of just being at high altitudes, the body makes more BPG during tissue hypoxia, such as in COPD and CHF, which you saw in cardiology. Not surprisingly, if you decrease these factors, you can get a left shift of the curve, which means increased affinity of hemoglobin for oxygen, thus less unloading of oxygen to tissues.
Think a lower amount of these factors means this curve is shifting left.
As we discussed earlier, the fetal hemoglobin curve is naturally a left-shifted curve because it has a higher affinity for oxygen than adult hemoglobin. Now, why is this important? Well, the fetus needs to steal oxygen from mom's adult hemoglobin. This is how the fetus will ultimately get its oxygen. It cannot breathe on its own and will therefore depend on the oxygen transfer from maternal to fetal hemoglobin. This, again, is mainly because fetal hemoglobin has a low affinity for 2,3-BPG, so at baseline the dissociation curve is shifted to the left, and hence there is an increased oxygen affinity. Finally, as we just discussed, carbon monoxide shifts the hemoglobin to the left and ultimately limits its carrying capacity because it physically binds to the oxygen site with a much higher affinity. Flash quiz. What is the effect of carbon monoxide on hemoglobin? Left-shifted binding curve and a decreased oxygen binding capacity because it binds the oxygen sites on hemoglobin.